what I've been asked to do today is talk about the importance of mental health, the importance of mental health on cancer care. And what I want to focus on in particular is why I think you should be interested in mental health. In other words, does mental health influence quality of cancer care? And I'm going to show you some theoretical data on that from the literature, but also some real data from real patients if time permits. If time doesn't permit, I'll give a synopsis of the clinical data to you. Now, one way to start is just to ask a question. Well, how do you define quality of care in general? And that is actually a tricky question from the literature. But this definition here from the US Agency for Healthcare Research is quite an attractive one. It's all-encompassing, but it's actually quite nice if you read it. Good quality care could be defined as doing the right thing at the right time, in the right way, to the right person, and having the best possible results. What I want you guys to think about in this presentation is, does a mental health complication impair those components? In some way, does mental health get in the way of your normal quality of cancer care? Because if it does, we really need to attend to mental health problems. So I'm going to set some context first. And the context is what's changed in the landscape of cancer care. And I know you know this data, but it's almost a refresher for me as much as a refresher for you. So you know that the incidence of cancer has been increasing in many cancers, for example, breast cancer, thyroid cancer, and that increase in incidence is about 20% according to CR UK. That's based on UK figures. But the same has happened in the US as well, an increase in incidence in the US with certain cancers. I know you can't read that. That's actually a live map from their website. You can actually go on and specify the cancer type, the period, and it'll show you the change with time. There's a nice option available there. But the real powerful thing is the change in prevalence, not incidence, isn't it? And that's the influence of increased survival. And the influence of increased survival is with the oncologist's ability to better treat the patients and also better detect them in terms of screening. And what that's meant in real terms is that if you take an average patient, then the outlook in terms of modal survival in the 1960s was approximately 1 year. And now we're looking at a modal survival of 6.7 years. And the 50% 5-year survival across the board was 50% in the 1960s. Again, an easy figure to remember, 50% 5-year survival. Whereas now the 5-year survival is approaching 70%. And by 2020, if trends continue, the 5-year survival across all cancers will be 80% chance of 5-year survival. If you think of particular cancers like prostate, they've done particularly well with a 90% 5-year survival across all prostates. Of course, we know the picture is more complicated than that because each cancer has a variety of stages and types, as you full well know. So what that's meant is we've got this new incidence pool, that's the number coming in with new diagnosis, but we've got a massive burden, roughly 3 times the number of new cases per year that are surviving with cancer. And the US data suggests that we've gone from 3 million living with cancer in 1970 to 13 or 14 million by 2010, with projected figures going up all the time. That is the burden. Now, if we think of that many people living with cancer across, how many would that be across the world? It's actually 25 million across the world, and it's probably more because we know in the developing world many cancers are under-detected. But if you imagine that pool, and then let's try and map on mental health, how would we even do that? How would we know how many mental health complications people have? Well, Professor Paul Simons and myself have been doing a lot of work on trying to map mental health aspects to the burden of cancer. And one way to do it is to say, well, let's take a very robust interview. That would be a high bar for mental health. And let's take the classic diagnosis, depression, which psychiatrists like me have been interested in for a long time. So let's take the high bar, let's take a psychiatric interview, let me go to the wards and interview all the patients with a standardized, structured interview, which increases inter-rater reliability and adheres to the current standards, which would be DSM. By the way, that's the Diagnostic and Statistical Manual for Mental Diseases, and a new version, DSM-5, just come out. Well, what would you get if you went and did all that work? Well, what you would get is 2 very tired people, exhausted by all the research, But what you would get worldwide is a map of what's happening with depression in cancer. And surprisingly, perhaps, if you crunch all this data from 70 studies in oncology and approximately 20 in palliative settings, then you get a take-home rate, which is actually quite robust. And that take-home rate is 15% major depression, 20% for less severe depressions, 20% for adjustment disorders, that's other emotional problems, and about 10%, at least interview-defined anxiety disorders. Now, because they all overlap, that adds up to a mental health problem rate, robustly defined, of about 40%. And that's on the day we interview the patients. You know, a random interview on the wards. And that is not different really in different settings. In fact, in our paper, which was in Lancet Oncology, this one, 2011, the rate was the same in palliative settings as it was in general oncology and hematology. So that 40% clinical rate is probably about right. And the rate of symptoms, people struggling with their symptoms, higher still. And we have some nice ways to measure the symptoms. You know, the problem with these studies, to be honest with you, is they require a lengthy interview. And I wouldn't expect any of you to have the time to do that in your busy practices. But you might have time to do a simple screener with something that can be reported simply by the patient. I'm going to show you a slide for that in a second, what you could use to elicit symptoms. But I just want to show you what happens with time, because this data is invariably early after the cancer, usually within 6 to 12 months, but maximum 2 years. What happens if you go to the community or go to primary care, still select cancer patients, but follow them for 5 years or follow them for 10 years? We've just done a study on that where we tracked the rates of depression and anxiety this time, over time. And these are the results. Basically, depression does systematically fall with time, such that after 5 years post-cancer diagnosis, providing the patient's not got undue burden or complications, their rate is actually the same as the general population. Their depression rates improve to the general population rate, which is a very good marker of success. And it's an indicator that although depression is high initially, if patients do well, it's likely they will recover in terms of the depression. But if you look at the anxiety bar, anxiety is more complex, and I've simplified it for this graph, but let me tell you what the figures show. After 5 years and after 10 years living with cancer, anxiety rates stay high, and even after 10 years, if you look at the surviving 10 years population, anxiety is 50% higher after 10 years than in the general population. Anxiety is staying high for a very, very long time. And it's not on this graph, but I'll also say what we did in this paper, which is just out last week, by the way, in Lancet Oncology. What we also looked at is anxiety and depression in relatives of cancer patients. And although, in my opinion, this is a somewhat ignored area, in relatives, they had higher anxiety rates, it was the spouses, than the patients themselves. And the sample size for the total number of cancer patients in this study, 50,000. 50,000. So the sample size is very large. It's fairly robust. Although this study, to be fair, didn't use that interview-defined depression. It usually used self-report scales. You may have heard of some, PHQ-9 or the HADS. So that is a limitation of this study. Now I said you don't necessarily need to use these advanced tools in clinical practice. So what tools would you use in clinical practice? Well, the tools that we've been using on the chemotherapy suite and on radiotherapy and elsewhere, Lorraine has been involved in some of these studies, studies using very simple, easy to complete questionnaires that basically are not a burden on you in terms of your day-to-day practice and not a burden on the patients. And this is called emotion thermometers. It's just a very simple visual analog scale labeled with distress, anxiety, depression, and anger. And surprisingly, these single item scales combined into a multi-domain one-page test, surprisingly accurate compared to the HADS or the PHQ-9, some of these classic psychiatric tools. And you can embed these in your routine practice in either a schedule which looks at unmet needs and then response of the staff. We looked at that. How did the staff respond to these problems? So you can embed these tools quite simply, either electronically or in a paper and pencil version, and they are reasonably successful. Now, one issue that's on here that I think is sometimes missed, but is really common sense, is what help do people want for these problems? And in addition, what is their underlying concern? So if these tools were too complex and you didn't want to look at distress, anxiety individually, you can ask the patient a very simple question, and I'm sure you ask this question all the time anyway, which is, what are you struggling with today? Just ask about the unmet needs. Just ask, what is the major concern? So we recently did this study in Leicester where we asked about unmet needs. And I know this is going to be invisible from the back, but after 540 assessments asking, what are you struggling with today? Out of the top 10 issues, 8 are psychological or emotional, or at least could be helped by somebody like me coming at things from a psycho-oncology point of view. Let me read you them, and these are in ranked order. And I haven't influenced this list. This is literally how the patients reported their unmet needs in Leicester. So number one, standout issue, worry about cancer, an anxiety symptom. And 37% had that symptom, not influenced by me. Number 2, sleep problems. Number 3, what they described as nervousness, but you might say another anxiety symptom. Number 4, fatigue, very common cancer-related complication. Number 5, issues with weight or eating. Number 6, a problem that, who looks after this problem? Memory and concentration. We can help with that, but who really helps with that? And you know that deteriorating cognition, particularly with some tumors like brain tumors or systemic tumors with CNS metastases, can be a red flag for deterioration. And the next one, I think 8, changes in appearance, 9, family issues, 10, depression and hopelessness. That is a very powerful list because I'm not influencing that list. That's literally as the concerns came back to me, 540 assessments. And this is not all theoretical. We're actually collecting now personal narratives of how people coped. And what we're using those personal narratives for is a form of peer support. So in psychiatric circles, we've spent a long time doing things like getting the patients together for group therapy. And that does work, but it's difficult to coordinate the right cancers and enough people at the right time. So we're actually putting together an online program, and I'll talk about that at the end if I have a chance. But online right now, in the pilot phase, it's not generally released. It looks something like this. Patients can go online, find their cancer type, and then hear a real narrative of a consenting patient, how they coped. Now, the reason I put this slide here in the talk is a reminder to me that certain patients, I'm not going to mention the names even though they are consenting at this stage, but certain patients told me in this program that their diagnosis was delayed because of their mental health problem, or their treatment was either delayed or not taken up at all because of their mental health problem. An example, there's a lady here who didn't receive chemotherapy because she was too anxious to go for the chemotherapy. It actually wasn't so much a provider issue. The oncologists were very willing and wanted her to have chemotherapy, but she refused it. And later she said the reason, when she came to see me, this is after the fact, actually more than a year later, after the chemotherapy was indicated, a year later she said, the reason I refused was I was too anxious about the side effects. This is an example from personal stories of how mental health influences the uptake of care. And just reflect on that, whether you've seen any patients with a similar story. And if not, is it worth asking about these kind of things? Now, there's other burdens of mental health on cancer care, and I want to take you through some of them now. So one of them is this old chestnut of what is exactly the relationship between these psychological problems and the burden of disease? And we've tended to play this down, but in my opinion, and from my research, it is actually very strong. So to put that in black and white terms, the more distressed or depressed the patient, the more burden they are experiencing. Now that is partly because if you have a severe disease, they're more likely to be depressed. But there's another direction to that, which is the more depressed they are, the less they're functioning, and the more they will perceive a burden from their mental health. It's a combination effect, a two-way relationship. And I want to show you the actual graph of this. This is the graph from Leicester, where we ask patients to rate their distress on those thermometers from 0 to 10. And then we just ask them to rate their daily burden. And daily burden could be defined as something really simple, like how often are you having problems on a regular basis carrying out your normal activities, being in a role at home or work, and sustaining your normal relationships. And then they just rate that on a very simple scale. Well, this is in grey, the percentage of people that say none, and that's mild, moderate, and severe. And you can see there's a very strong linear relationship between more distress and more burden. And remember, that is a two-way relationship. Now, when I present these kind of data to oncologists and hematologists, they often go, yeah, I kind of expected that. But what they often want to know, particularly the medics, they want to know about mortality. Is there an effect on mortality? I've heard that mental health could affect mortality. What is the story behind mental health and mortality? Well, before I go and say what's the effect of mental health on cancer mortality, what's the effect of mental health on its own mortality? For example, if you have depression or schizophrenia, do you have actually reduced mortality? And you guys might not know, but if you look at the data and compare different diseases, I'm going to skip this first slide because this is data you do know. This is the years of life lost through each typical cancer diagnosis based on American data. But if you rank all diseases and then try and put them into a table from international data, WHO, or American data, they've got a website. If you look it up on Google, SEER, S-E-E-R, you can actually rank all the conditions by years of life lost. And it looks something like this when you rank the data together. So the mean years of life lost if you have a cancer, it's here actually, and I've highlighted it in green for you. 15.4 years. That's the premature death effect of having a cancer. Now, what the two factors come into this. It's how aggressive the disease is and the age in which people are typically diagnosed. Because if you have an aggressive disease at an early age, you lose more years of life. Does that make sense? So, for example, cirrhosis of the liver is actually worse statistically in terms of years of life lost. But look at schizophrenia. Schizophrenia on its own has a years of life lost effect of about the same years of life lost that cancer has. Of course, it's not such an aggressive condition on mortality. It's a very subtle effect, usually on cardiovascular disease. But nevertheless, the age times that modest effect causes a ballpark figure, which is roughly the same. Now, what happens when you combine a mental health and physical health diagnosis together? This is a paper in the JAMA Psychiatry by Kisley and David Lawrence. And what they did is they looked at survival with cancer in a large Australian data set. It's actually 6,000 patients with a variety of cancers. And then they looked at all the mental health combinations, so with and without each mental health problem. So for example, just picking one at the end here, if you have schizophrenia, your relative risk of mortality, so that's the two percentages of mortality compared, was twofold. It was twofold worse if you had schizophrenia. And if you had alcohol problems, dementia, depression, they were all worse, a worse mortality if you had the combination of mental health and a cancer compared to those with the cancer alone. So that is a red flag to say, you know, what is going on there? Why are patients having this inferior mortality if they have a mental health condition? And even if you have a symptom, this is really quite astonishing now, even if you have a symptom of a mental health problem, for example, hopelessness, then your mortality over 5 or 10 years appears to be worse. And as a ballpark figure, it's between 10 and 20% worse. So 10 and 20% worse over a period of time. And that's a modest sample. Okay, there's only 500 in that sample. If you want to look up that paper, it's by Maggie Watson in European Journal of Cancer, and the year was 2005, a little time ago. And that reminds me, that difference, 10 or 20%, reminds me of the kind of ballpark you would get if you stratified people by adherence to mainstream oncology treatments, such as adherence to radiotherapy. And I just looked this up for this talk. What is the difference in survival if people complete radiotherapy as per protocol, as per design, and if they drop out of radiotherapy or it goes wrong? And this is a paper that is by Abrams, so if you want to look that up, by all means do so. And the ballpark figure there was actually a 25% difference in survival down to adherence with radiotherapy. It reminded me of that kind of ballpark figure. And it also reminded me that there's a difference, obviously, the classic difference by staging of cancer. And the ballpark figure between, let's say, localized and regional disease is about that same kind of ballpark that we're talking about. So what can explain these differences? Well, if you take an individual patient, this puts it into perspective. Take an individual patient who has lung cancer and then stratify a typical patient with schizophrenia and lung cancer and a typical patient with lung cancer and no schizophrenia. Then the modal months of survival for a lung cancer patient, and this is new data that's in press in a journal called Psychosomatics, the modal survival time is 26 months without schizophrenia. But with schizophrenia, for similar patients in the same center, 22 months survival. We've got a difference there, with presumably other factors controlled, assuming that people are treated equally, if we can make that assumption. Well, that is actually a dangerous assumption in itself, and I'll show you why in a second. Now, the question then is why? What is going on behind all these inequalities according to mental health status? And one possibility that we've been looking into a long time, not so much our group, but elsewhere, this has been very fashionable in psycho-oncology, is the idea that if you have a positive outlook, like a fighting spirit, they sometimes call it, I'm going to do well, I'm going to beat the cancer, then your survival will be superior to those without. And if that was the case, that would be very attractive, because we could help people in group or in psychological therapy, and then those that were helped by us would do better, wouldn't they? And that's been done classically in the States by a chap called David Spiegel, who enrolled 89, I think it was, advanced breast cancer ladies into a trial of group therapy, and then he actually stratified them by those with a positive outlook and those that were kind of giving in. And he tried to treat them to see if it would make a difference. And he did show an effect. That was all over the press in about 1990. But all replications of that attempt failed. That was an outlier false positive. And in fact, in an adequate sample, 275, in a paper that was published in New England Journal of Medicine, if you want to look it up, Pam Goodwin is the first author, the ability to change somebody's psychology and then enhance their survival was shown to be a null effect. It doesn't work like that. In other words, you cannot, as far as we know, intervene in the psychological outlook and improve the survival. Even though there's these inequalities that do affect survival, intervening hasn't been shown to make a difference. So something odd is going on when we can't intervene. And the same effect has been shown with antidepressants. It's not just psychological therapy or group. If you want to look at antidepressants, a nice paper in 2007 in Lancet Oncology, Stockler is the first author, looked at what happened when we put patients with cancer on antidepressants. Was their survival different? And basically this trial was actually stopped prematurely because the antidepressant arm did worse. They actually had worse survival, although to be totally honest with you, it was a temporary effect. And at the end of the study, they said that there were no effects, but it certainly wasn't an advantage of being on an antidepressant. So being treated with an antidepressant did not improve survival. So what I'm saying there is whatever intervention we're giving, it doesn't really seem to affect survival. But don't get me wrong, it does affect quality of life, it does affect well-being, and it does affect ability to carry out daily function, and it does affect people's ability to go back to their normal role. All those key normal objectives that we know, call those quality of life if you like, it does affect, but it doesn't affect survival. So there's some other mechanism going on other than the psychology influencing the aggressiveness of the cancer. And if you take a step back for a second and look at some more inequalities in relation to mental health, one, and this happens to be a slide from the Canadian Manitoba district uptake of mammography according to mental health status. The take-home message from this study, and we've recently done a meta-analysis on this, although it's not published, is that the presence of mental health affects the uptake of preventative screening. So people who have a mental health problem, particularly schizophrenia, the actual rate of difference, 30% less in those, that's by odds ratio, 30% by odds ratio, of those with schizophrenia had that lower uptake of mammography, not just in this study, but in 15 studies worldwide. So there's something going on the screening front, and there's something linked with mortality, but no influence of an intervention. So, okay, let's go back to basics here. Maybe the effect is with uptake of care and receipt of care. And that Bergamon study that I just told you about that's in press, the one that showed the difference in lung cancer survival, they went back and looked at their patients according to mental health status, and they looked at how many were receiving treatment for their lung cancer. Now understand, all these patients had lung cancer. The question was, were they being treated for it? So you'd think, well, they're all going to be treated. That wasn't the case. In fact, receipt of surgery was 10% difference according to mental health status. Receipt of chemotherapy, about 3% different. And receipt of radiotherapy, about 10% difference. And all told, the rate was about 11% difference if you had a mental health problem. Now, I'm talking about severe mental health problem. I know that. And there could be an explanation like the patient's refusing. That's possible. But even if they're refusing, a service like mine should work together with the oncologist, helping understand what's going on and trying to influence the patient. And there's another study that's just come out, actually, 2011, by Balajan, that looked at the rates of diagnosis. Though that previous study was very small, but this one is very large, 500,000 subjects in this population-based study. They looked at the colorectal cancer treatment. So what they did, just to explain this, is they looked at everyone with a colorectal cancer that was proven at post-mortem in France, I think it was. And then they said, of everyone with a known colorectal cancer, how many received treatment for that colorectal cancer? And in the general population, the answer was 98%. 98% were treated for that colorectal cancer. That's here, 98% treated, 2% untreated. But then they looked at everyone with a mental health problem. And if you look, if you had a substance abuse, that's alcohol or drug problems, depression, any mental disorder, psychotic disorder, that's basically schizophrenia, or dementia, you can see your rates of no or null treatment were much higher. It doesn't give you the explanation, but it tells you the rates are disproportionately affected. They're unequal. There's an inequality there. And that's the rates of no treatment. They also looked at whether, remember I said the diagnosis was initially post-mortem. They looked at the post-mortem diagnosis of colorectal cancer. Then they went back to see whether the patient had the diagnosis in the notes, diagnosis in life. And the same effect was there. Patients with truly post-mortem, true colorectal cancer, in the general population, 99% were correctly diagnosed in life. But not if you had a mental health condition. The rate of pickup for a colorectal cancer in life, as opposed to just finding it post-mortem, was significantly different according to the mental health condition. And the numbers are huge in this study. It's one of the most robust studies ever done. 500,000 in those with any mental disorder. And dementia was the worst offender there. Now, if immediately I say dementia, you'll be thinking, that explains it. There's patients who are not suitable for treatment or not taking up treatment. They're too unwell to do the investigations. I do admit they're all possibilities, and they will explain some of the numbers. But if you look at a parallel here, a parallel to another big inequality, which I don't think we talk about much, but credit to the Leicester team, not really me, but Professor Simons and colleagues, they've been looking at ethnicity as a factor, not just in relation to mental health, but in cancer in general. And one interesting finding here is about the effect on depression and anxiety. And you may know this study. I don't know if it's been mentioned today already, but Professor Simons and myself just published a paper in BMJ Open, and the first author on this is Karen Lord, who did this fantastic work for a PhD. What she looked at was whether the rates of depression and anxiety and other factors are different in those British white patients compared to British South Asian patients. And if you take a simple scale like the PHQ-9, the rates were approximately twofold different. So in other words, the rate of PHQ-9 positive, which in just layman's terms is they're depressed. They have sufficient symptoms that we'd call them depressed. In the British white cancer patients, it was 18%. But in the ethnic minority in Leicester, which comprises, a significant number, somewhere between 30 and 40% in Leicester City, then we're talking about 35% rate of depression. In other words, there was a twofold rate of depression, difference in depression just based on ethnicity alone. Now, that's not why I wanted to put this slide up. I want to put it up about treatment inequalities, because I think it tells us something about mental health treatment, because we have a similar problem in relation to ethnicity that we do in relation to mental health. And that problem is also hinted at here. From American data, if you're an American white middle-class person, your cancers, your treatment of your cancer is pretty good in the US, as you'd probably expect. But if you are in an ethnic minority, particularly African American, black person, particularly poor black person, then you are subject to inequalities which influence your cancer survival. that influence your cancer survival. That is historic data, but it's still true now. In fact, that inequality arguably is not narrowing as far as I know. Now, the reason I really put this up is because in the inequalities due to ethnicity, we do have a hint that what's going on. We have a hint of an explanation. And the hint of the explanation here is from this paper in journal JCO, which is by Leicester et al. And they looked at what explains the inequalities according to ethnicity. Now, the number one was that the surgeon who was considering surgery for lung cancer decided that on the basis of ethnicity, although they didn't spell it out, that was the end effect, that on the basis of ethnicity, that the surgery was contraindicated in that patient, but there didn't seem to be any other explanatory variable. And not shown on this slide, but where the patient didn't have the indication of don't do the surgery, i.e. contraindication from the surgeon, i.e. the surgery was not contraindicated according to the surgeon's judgment, then surgery still wasn't recommended with a 10% difference between those in an ethnic minority and the general non-ethnic minority population. So something is going wrong or there's something is different anyway regarding provider attitudes. And this is reflected in this slide. Provider attitudes, in my opinion, is reflected in this slide. Let me just quickly explain this. This is a US slide about care for cancer across approximately 20 Florida cancer centers. Each letter is a different center, equivalent to Leicester or Derby or Nottingham. Each one is a large center. Now, in the red, you've got care for patients for their pain. And in the beige, you've got care for patients for their emotional problem. And what they did is they tracked how many times were the nurses in each center attending to pain for the patients who flagged, I've got a problem with pain. Okay, how many times is that being attended to? And they compared the two domains, pain and emotional problems. Now, across all centers, pain was attended to in 80% of patients, but emotional needs were only attended to in 50%. But there was tremendous variation from centers which were quite modest in both domains to centers that were very good. And I can only speculate that some centers had some organizational differences that helped them in both areas and some did not. And that's a prompt to say, well, what's your center like? How are you in your center organized for looking at the emotional needs or the physical needs? Because I bet you're pretty good at the physical needs. But are you good at the hand on heart on the emotional needs? And just this year, there's been a replication of that by Johnson in Denmark. And they did a really nice study where they didn't just look at pain and depression. They looked at pretty much all unmet needs. And they first said, how common are they? That's like the slide I showed earlier, 540, most common being anxiety and worry about cancer returning. And I'll tell you, the ranked order of needs which were addressed to unaddressed. So this is most addressed. It occurs regularly, but it's most addressed by the cancer clinicians. And this is least addressed. And this actually leads to our next talk. Hopefully not at this second, but in a few minutes. So the most addressed was pain, followed by nausea, shortness of breath, appetite. The top four most addressed were all physical symptoms. What comes after the physical? Depression, work and activities, returning to work, physical activities in general, fatigue, relatively unaddressed. Whose responsibility is it? We still have that problem for fatigue. Worry, very much unaddressed. In fact, only 20% said their worry was addressed to a satisfactory degree. Family and friends issues, i.e. relationships. Concentration and memory, we mentioned it before, didn't we? Only 10% said it's satisfactorily addressed in their cancer center in Denmark. And least addressed, to be followed later, shortly, sexuality as a complication of cancer. And that's one of the best pieces of research that I've seen come out this year, in my opinion. So where are we going with this, and what's happening regarding mental health treatment? Are we actually making a difference to our patients from a mental health point of view? Well, we've recently looked at this in terms of a very simple question. How often do clinicians working in cancer centers around the world attend to mental health needs, according to the published literature? And from about 20 studies, the result is 40%. And what does that mean in practice? We found exactly the same thing here. Lorraine and I and Professor Simons found the same thing here. When a patient flagged a problem on our thermometer and said they had an unmet need, the frequency with which the nurses or radiotherapy specialists or treatment radiographers attended to those needs was about 40%. In 60%, when I collected the data, but this is also backed up in the worldwide data, those needs weren't being addressed. Now, when I talked to the staff individually, they said, oh, but I talked to that patient. I just didn't think that was what you meant by helping them. And I said, no, that is quite valid. You can offer frontline support, and that is good, but return that to me as a piece of data in the future. So to some extent, we may be underestimating our effect. But I still want you to keep mental health on the agenda, because from the worldwide literature, yes, it is undertreated. And I'm skipping this for sake of time, but we have looked at studies in the literature, this one's by Hewlett and Rowland, that have compared the adequacy of treatment in a mental health setting, primary care and cancer. And in terms of cancer and primary care, it doesn't seem to be that different. In other words, that 30 to 40% rate applies in primary care, it also applies in cancer settings. We also asked the chemotherapy nurses and treatment radiographers whether they recognized the problem. And this is their rate of recognition based on the severity of distress. And although they recognize more severely distressed patients, across the board, they only recognized and detected about half of cases. And the cases that they managed to detect most of all was broadly defined any emotional problem. Like, I don't know what it is, but the patient's struggling, which is quite valid if you're going to follow that up, that's a reasonable start. Also anxiety, they didn't do too bad, about 43% detection. But in terms of depression, core depression and core anger, those were quite overlooked. So I've literally got 1 or 2 minutes, I hope. I'm going to just tell you where we're going now in Leicester to try and improve these inequalities. If you think about that slide I put up at the beginning, I've kind of made the case that in relation to mental health, we can't really say we're always doing the right thing to the right person at the right time in the right way. So we have got issues there. So we need a systematic way to address inequalities, but we also need nice interventions, don't we, that are simple, a simple detection method and a simple intervention. And I'm going to talk you through a couple of interventions we're developing. One is self-help material. Self-help material, jargon term in the literature, bibliotherapy. Basically information, but not just passive information, about your cancer stage, your prognosis, your treatment implications. That's important, but actually a form of therapy in a booklet, tailored somewhat to the patient. And we call that the Difficult Emotions booklet. It's got forms of mental health treatment in there. And our aim is to trial this in Leicester in an RCT and then make this generally available to everyone on the internet, or possibly just in the old-fashioned way, in booklet form, but widely distributed. And the problem I found with this is the patient's got to be able to read, the patient's got to be motivated to do it. I've still got to hand it out, and the patient's got to be able to work through it. In fact, it's a 4-week program over 32 pages. Now, the uptake isn't bad, but you would anticipate around 50% are successfully able to do a bibliotherapy-based package and get better from it. About 50% are able to do it and potentially get better. And that's perhaps with assistance. That's assistance of our team. So that would be assisted bibliotherapy. But I actually think now a much more powerful strategy is to do something that's very widely disseminated. For example, nationwide or international. And I mentioned this thing about Cancer Stories earlier. Cancer Stories is a peer support program on video where we ask patients to give their consent, to give their true account of how they managed with their disease. And they do that in a mini studio that we've set up over 30 or 60 minutes. And they give their honest account, which patients find therapeutic for themselves and their families. In fact, I have a regular request from patients who have advanced disease, particularly those who are terminally ill, to make a video as a legacy for themselves and their family. That can be very powerful. But in fact, beyond the legacy video, which has actually been done before, I'll admit, recording the story for the benefit of new patients, particularly inspirational stories or stories where people have found resources of how to cope and what to do, what's available locally or regionally or nationally. That can be really powerful. Now the thing here is, this is a form of peer support where I'm actually going to distribute it over the internet, and it's going to be freely available online. That is actually a mock-up of how it looks online. Each one of these is a story which has a demographic and a cancer type and a stage. And naturally what the patients do is they go and look up their cancer type, have a look at one or two of those stories. If they're inspired by it, they may look at some others. And we're collecting feedback in a pilot stage right now, but it is very, very well received. And there will be some other high-tech options coming along for those that are very well empowered in the IT world. And I realize that's not everyone in our demographic, but it is a surprising number. So one last thing, what if the patient cannot go online and we cannot help them? The online facilities available in the cancer center, for example, Macmillan Support Wing, but we also record the story to DVD to give them a DVD copy. And where, in a very, very rare case, 1% of patients, they don't have a DVD player or the internet, then we actually loan out a DVD player, one of those little car players, you know, that people can take round. Then they watch the story, see a collection of DVDs, and then come back and give the feedback. I'm not standing here saying this is the only thing we should do for patients. This is actually a modestly powerful intervention, but it's going to be very widely disseminated, hopefully nationwide. A modest effect over a very wide number could actually be more powerful than a slightly larger effect from myself in the clinic, but given to only a few people. So this kind of thing, I think, is going to be the future of psychological and emotional care, but it always supplements what you're doing yourselves on the front line. So bear in mind the inequalities, bear in mind that effect on mortality. Although I said there's a null effect on survival, there is an effect of your intervention and mine and all of ours here on quality of life and well-being. And that's what I want you to take back to your clinic and your hospitals. You can make a difference to the patients. But watch out for cancer stories as well. I'll be helping you make a difference even more in the future. Thank you very much.